Hello, everyone, and welcome. I'm Marcia Mott, and I'm the coordinator for UF Health Wellness University. We have a great presentation today about addiction. This is a topic that's near and dear to my heart, since I grew up in a family affected by alcoholism. My father recently celebrated 39 years of sobriety. I'm very proud of him and his commitment to helping others who are dealing with this cunning illness. I want to remind every one of you that you're not alone. There is help and there is hope. Today, our speaker is Dr. Jason Hunt. Dr. Hunt is board certified in addiction medicine and joined the faculty at the University of Florida Recovery Center in 2017 to practice addiction medicine. If you have a question for Dr. Hunt, you can submit a written question at any time using the Q&A button at the bottom of the screen. At the end of the presentation, I will read your question, but I won't identify you in any way. We will only be accepting written questions, and I'll do my best to get through as many questions as possible. Most Americans have been touched by addiction in some way or another, and I hope this presentation today can help you or a loved one. Dr. Hunt, I'll turn over to you now. Thank you.
Thank you, Marcia. I appreciate that, and I appreciate everybody being here for this talk today. I have a lot of information to share, so I'm going to go ahead and get started. When we discuss addiction, it's impossible not to talk about stigma. The stigma of addiction and stereotypes of people with the disease impact our policy decisions and the way we have shaped treatment for the last century. Understanding that addiction impairs the brain may reduce stigma. Perhaps most importantly, the biologic basis of this chronic disease is a strong argument for parity, that is, treating and funding treatment for addiction equal to other biologic and chronic diseases. I've seen firsthand here at the University of Florida, UF Health Florida Recovery Center, that this disease does not discriminate. Although we specialize in treating doctors, lawyers, nurses, pharmacists, and other healthcare professionals, our patients really make up all walks of life. We treat mothers, fathers, sons, daughters, and most come in with some shame and guilt over some of the things they've done in active addiction. And invariably, when all the dust settles and they have started to embrace recovery and treatment, and I ask the person that they're becoming today, would they do some of the things they did in active addiction? And their reply is always no, because none of them are bad people. They're good people with a bad disease, and one that presents itself as bad behavior, or can present itself as bad behavior. So what could explain such poor decision making? Hopefully after this talk, you'll have a better understanding. I do want to make it clear, I'm not making excuses, but I'm hopefully providing more of an understanding. We've come a long way in our understanding of addiction. Everybody remembers the 80s campaign, this is your brain on drugs. Well, on the right, this is literally your brain on drugs today. A person's brain on cocaine, and the areas of the brain highlighted in yellow where the cocaine is binding and causing its changes. From Dr. Nora Volkoff, the director of National Institute on Drug Abuse, as she says, as we have seen repeatedly in the history of medicine, science is one of the strongest allies in resolving healthcare crises. Ending the opioid epidemic will not be any different. In the past few decades, we have made remarkable strides in our understanding of the biologic mechanisms that underlie addiction. Scientists and doctors are continuing to study the brains of people suffering from addiction, and she goes on to say that addiction changes the brain in ways that even when people quit can leave them vulnerable to relapse, changes that researchers believe lessen with long-term abstinence. So what is addiction? Is it a choice? Is it a weakness? A physiologic dependence? Is it a learning disorder or a lack of willpower? Or what about an amoral condition, or the age-old argument that it's a sin? Well, it's a brain disease, and decades of neuroscience and research have revealed addiction to be a chronic brain disease that changes the brain. Some of these changes quite possibly might have been there prior to first use, secondary to environmental changes, stress, and even trauma. But addiction is typically characterized by compulsive behavior, loss of control, craving, and persistent changes in the brain's structure and function. This is a definition of addiction from the National Institute of Drug Abuse, a chronic relapsing disease characterized by compulsive drug seeking and use despite harmful consequences, as well as neurochemical and molecular changes in the brain. It also goes on to note that brain imaging studies show changes in the brain that are critical for judgment, decision making, learning, and memory, as well as behavioral control. ASAM, the American Society of Addiction Medicine, uh, just recently, earlier this last year, um, released a new definition of addiction to advance greater understanding of the complex chronic disease. And it reads, addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. And prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. However, my favorite definition of addiction is from Motley Crue's Nikki Sixx from his book, The Heroin Diaries, which says addiction is when you can give up something anytime you want, as long as it's next Tuesday. And that bears to be true, right? When you can quit, you don't want to. And when you want to quit, you can't. Pretty much sums up addiction. But when we mention that addiction is a disease, it's often met with a lot of eye rolling, questioning. You're making excuses for their bad behavior. Critics of the disease model of addiction don't seem to mind the words illness, affliction, sickness, malady, abnormal condition, problem, defect, or disorder. I'm not so sure why we have to complicate it. All these terms are really synonymous with the same thing, with the word disease. But there's something about the word disease that really can ruffle some feathers. So let's examine the definition of a disease. If you were to look at any medical textbook, dictionary, or Wikipedia these days, you would find basically the same definition of the word disease. A disease is any condition which results in the disorder of a structure or a function in an organ or organ system that causes specific signs and symptoms. So it's basically an organ or organ system with abnormal structure and function, a defect, something that's not normal that leads to reproducible symptoms. If you take diabetes, for example, the organ is the pancreas, a much more simple organ than the brain. We know much more about the pancreas, and we're still learning much about the brain. The defect in diabetes is an impairment in beta cells or changes to the insulin receptor, leading to insulin resistance, which causes the symptoms that are associated with high blood sugar. Heart disease or hypertension. The organ is the heart and the circulatory system. The defect is in the renin-angiotensin system, and it leads to symptoms of high blood pressure. In addiction, the organ is the brain. Like I said, a very complicated organ that we're still learning much about to this day, and its related neurocircuitry. The cortex, midbrain, and limbic system are also known as the reward pathway. The defect is a stress-induced dysregulation or dysfunction of this dopamine reward system and its related circuitry that we'll talk about later. And the symptoms are well characterized and described in the DSM-5 and the 11 criteria of substance use disorder, which I will also talk about a little bit later in this presentation. However, the disease concept of addiction is not new. Disease addiction has been discussed as a disease going back to the 1700s and probably even earlier. Dr. Thomas Trotter was the first to characterize addiction as a disease or a medical condition. Dr. Benjamin Rush, who's commonly known as the father of modern psychiatry, uh, went on to say that habitual drunkenness should not be regarded as a bad habit, but as a disease. And even Abraham Lincoln in 1842, non-alcoholics have absence of appetite rather than a mental or moral superiority. And victims of it were to be pitied and compassioned, just as are the heirs of consumption and other hereditary diseases. And I find it interesting that he mentions absence of appetite, which we would think today as no craving. So the difference is people with addiction, their brains can create craving versus those that don't. The AMA in 1956, the American Medical Association, classified alcoholism as a disease and followed closely in 1987 by saying that all drug addictions are one disease. The leading medical journals recognize substance use disorder or addiction as a disease. This is an article from the New England Journal of Medicine, one of the world's most known medical journals. And then 2016, the American Board of Medical Specialties recognized the subspecialty of addiction medicine. Now, it's regarded as no different than any other specialty or subspecialty in medicine, such as surgery, internal medicine, OBGYN, pediatrics, family practice, and others. We have the same, and now training programs uh, to further this field. However, many members in our field, the field of addiction medicine, are frustrated that the public does not see addiction as a legitimate medical disease, which should be compassionately addressed as a health problem rather than a criminal justice issue. And although some attribute this to lack of scientific knowledge or attachment to an outdated moral view about addiction, and we do need more education, but we also must acknowledge that addiction is different from some medical disorders because of its extreme consequences and externalities, meaning harm to others, which understandably makes the public more fearful and angry about addiction than they are about conditions like asthma, type 2 diabetes, and even hypertension. There'll never be a MADD, MAD, Mothers Against Diabetic Drivers, and that kind of exemplifies the stigma against addiction. Relatedly, because of the amount of violence and other crimes associated with addiction, we should acknowledge that the public's belief that law enforcement has a role to play in responding to addiction does have a rational basis. And in some instances, it's very good that they do. Most people do enter treatment via the criminal justice system. We do need more treatment courts, but about 70 to 80% of people will enter treatment from a nudge from the judge. Do you know how many enter treatment typically referred by a physician or a healthcare employee? It's really only about 3 to 5%, so much lower. The statement from Kelly Clark, who was the previous ASAM president, she says addiction is a chronic, multifaceted brain disease that requires specialized training to treat it effectively. Yet most doctors leave medical school without education in addiction medicine. Hopefully that is improving as we add more and more training programs to our medical schools and our hospitals. They're starting to give recognition to several schools for the training that they're offering in addiction medicine to their medical students. Um, I know here at the University of Florida, it's something that we're very, very proud of. We have actually been training medical students for over 20 years, and we're the first to do so and the first to make addiction medicine part of their core curriculum in their third year as medical students. We've also trained more addiction medicine fellows than any other fellowship program in the country. When I first applied to the fellowship, there were only about 11 programs, and now with the growth, there's I think more than 70 addiction medicine fellowships currently. Both our last two Surgeon Generals, addiction is a brain disease. You can see Dr. Murthy says we have to help our country see that addiction is not a character flaw or a moral failing. It is a disease of the brain. And the most recent Surgeon General, Dr. Adams, we will not deny, or as physicians, we must say loudly for all to hear, we will not deny treatment to individuals with the brain disease of addiction. Addiction is like other chronic diseases. It's highly treatable. The one thing we do not talk enough about is that most people will get better. A lot of attention has been paid to the devastation of the opioid crisis, yet the reality is addiction treatment does work. There's also similar treatment outcomes and management strategies. Outcomes are also similar to other chronic diseases like hypertension. But part of the problem is that we have built a system as though someone can go away for 30 days and be fixed with these short episodic treatments. And then we blame the patient when they don't get better. We would never do that with any other chronic disease. It's also like other diseases in that it's highly genetic with significant environmental factors, up to 40 to 60%. Like heart disease or diabetes, half is genetic and half is environmental. Biological factors that can affect a person's risk of addiction include their genes, the stage of development, and even gender or ethnicity. Scientists estimate that genes, including the effects environmental factors have on a person's gene expression, called epigenetics, account for between 40 and 60% of a person's risk of addiction, which again is similar to diabetes and heart disease. Also, teens and people with mental disorders are at greater risk of drug use and addiction than others. And though genes can be a predictor of addiction, genes are not the sole cause of addiction. Yes, addiction is inheritable, but so is recovery. Stress, Chronic, severe, repetitive can be inherited or derived from something that happened early in life or can be caused by trauma or PTSD. Children's earliest interactions within the family are crucial to their healthy development and risk for drug use, which can be measured by an ACE score, adverse child experiences. Addiction, like other chronic diseases, does involve lifestyle choice and lifestyle modifications, as the case in other chronic diseases in which voluntary unhealthy behaviors contribute to disease progression, heart disease, diabetes, chronic pain. A better understanding of the brain disease of addiction may help to moderate some of the moral judgment attached to addictive behaviors and foster more scientific and public health oriented approaches to prevention and treatment. Like other chronic diseases, the goal is prevention of acute and chronic complications like overdose and hepatitis C with addiction. There's also similar relapse rates, which we will discuss some later. Relapse serves as a sign for resumed, modified, or new treatment. Like treatment of other chronic diseases, it involves changing deeply rooted behaviors, and relapse doesn't mean that treatment has necessarily failed. When a person recovering from addiction relapses, it indicates that that person needs to speak with their doctor or therapist, peer support, and possibly resume treatment, modify it, or try another treatment. Addiction is similar to other chronic diseases, such as heart disease. Both disrupt the normal, healthy functioning of an organ in the body. Both have serious harmful effects, and both are, in many cases, preventable and treatable. If left untreated, they can last a lifetime and may lead to death. Using imaging technology, like on the slide, to measure metabolism, in this case, glucose uptake in the brain and heart, one can see that both addiction and heart disease produce observable changes in structure and function. In each pair of images, the healthy organ shows a greater activity of red and yellow than the diseased organ. Nobody would argue that this is not a diseased heart on the right and a healthy heart on the left. Diseased heart, healthy heart. But we do get a lot of argument about a brain disease or a diseased brain and a healthy brain. And you can see in the healthy brain or even in the diseased brain that the frontal cortex, which is the part of the brain that is associated with judgment and decision making, is significantly affected with decreased function in the diseased brain or in the person with the brain disease. SPECT scans show blood flow and metabolism in the brain that are severely compromised in addiction and has demonstrated many abnormalities in areas known to be involved in behavior. Examples here show changes from the use of alcohol, cocaine, marijuana, and heroin. The good news is these findings can improve with treatment and abstinence. Again, addiction is a brain disease, as in other diseases that affects function. The focus in the past has generally been on drugs. It is clear that addiction is not just about drugs, but it's about brains. It is more about neurocircuitry, brain pathways, changes in structure and function, and what goes wrong, especially in critical areas for behavior and decision making. Addiction is basically a tale of two different brain regions: our rational brain, the frontal and prefrontal cortex, and our survival brain, the midbrain limbic system reward pathway. Addiction is a repeating cycle with three stages. Look at the three stages. We have the binge intoxication stage, which is exactly what it says, using in excess and the euphoric effects. The withdrawal negative affect stage is the stage at which one experiences the negative physical, emotional, and even pain state of withdrawal, even acute or prolonged. And then the preoccupation anticipation stage, the stage at which one craves, seeks substances again and again after a period of abstinence. These three stages are linked to and feed upon one another. They're each associated with a particular brain region that we will discuss next. A person may go through this cycle over the course of weeks or months, or progress through it every hour or several times a day. And it only gets worse over time, and explains why in addiction people can have a sincere desire to quit and yet simultaneously be impulsive and unable to follow through and stop despite negative consequences. I have coined the terms, and I consider these stages the high, the hell, and the hunger. Um, and that's exactly kind of what they produce. These three stages are a lot more complicated than we're leading on here. This shows some of the neural circuitry and the neurotransmitters that are associated with them, as well as the brain region associated with each stage, the binge intoxication stage being the basal ganglia, the withdrawal negative affect stage being associated with the extended amygdala, and the preoccupation anticipation stage with the prefrontal cortex. There are neurobiological circuits that drive these domains and these regions of the brain, leading to dysfunction. On the left is a list of these multiple brain areas that correlate with each stage, but we're only going to address the most important ones here. And there are neurotransmitters responsible for everything we do, everything we think, everything we feel, and the structure and function of the brain are shaped by genetics, environment, and behaviors. It is this complex interaction among these factors that underlie addiction as well as recovery. Again, in addiction, the organs of the brain and its related circuitry, the cortex, midbrain, and the limbic system, also known as the reward pathway. Briefly, the prefrontal cortex is responsible for our executive function, kind of like the bridge of the ship. The basal ganglia and kind of the blue-purple, which play an important role in positive forms of motivation, including the pleasurable effects of healthy activities like eating, socializing, and sex, and are also involved in the formation of habits and routines, as well as forming and learning bad pathological habits. These areas form a keynote of what is sometimes, again, called the brain's reward circuit, and include the dorsal striatum, which is also involved in forming habits and other routine behaviors, the nucleus accumbens, which is our kind of our motivational motor. It gets us to act, it gets us to pursue a goal, it gives us the motivation to go after something we want, and it's where we experience reward. The VTA, or the ventral tegmental area, is kind of referred to as like the dopamine machine. It supplies dopamine to the nucleus accumbens and tells us how important something is and if we need to pursue it, and at what cost should we go after it. Drugs overactivate this circuit, producing the euphoria of the drug high, but with repeated exposure, the circuit adapts to the presence of the drug, diminishing its effects and making it hard to feel pleasure from anything besides the drug. As anyone suffering from addiction will tell you, at the end, it's not fun anymore. A closer look at the area, especially the prefrontal cortex, which is responsible for complex cognitive processes described as executive function, which gives us the ability to organize thoughts, activities, prioritize tasks, manage time, regulate actions, emotions, and impulses. It's where we make decisions. It's where we know right from wrong. It's where we weigh our consequences and learn from our mistakes. It's where our morals, our values, our empathy, our spirituality lie. It's where mother loves child and where child loves mom back. Love activates the brain reward pathway. This is the first image of a mom kissing a child. And even this can be taken over and disrupted by the power of addiction. If you look on the far right, this is also the last part of the brain, the prefrontal cortex, to mature, making teens most vulnerable. The fact that the prefrontal cortex, um, the critical part of a teen's brain, is still developing puts them at increased risk for trying drugs or continuing to take them. Introducing drugs during this period of development may cause brain changes that have profound and long-lasting consequences. On the flip side, if they do seek treatment earlier, the neuroplasticity of the brain and the still fact that it's still maturing, they also can heal better or quicker. The midbrain, again, part of this survival, part of this reward pathway, our survival brain, or our reptilian brain, or primitive brain. You may have heard all these terms to describe this midbrain and reward pathway. It's our motivation and drive for survival. It really only cares about the next 30 seconds of our lives. Its real only concern is what's going to kill me and what's going to save my life. It tells us to run or fight when we're threatened, eat when we're hungry. It's responsible for our sex drive. It tells us to drink when we're thirsty. Have you ever been really, really thirsty or really, really hungry? Well, just shut it off. Well, you can't, because this area guides the behaviors that are most essential to life. You can't control this system with our rational mind. We don't have the wiring to do that. And if you think about it, there was never a reason in evolution for our rational brain to be able to shut off these limbic system survival drives. When you feel hungry each day, it's not because you use your rational, logical brain to figure that out. You just feel hungry and have the compulsion to eat each day. And if you attempt to shut this off, you're hungry, shut off your hunger, it simply doesn't work. You will just become more and more uncomfortable until you eventually eat food. Uh, However, the limbic system, does have the widespread connections throughout the brain. And when it desires something, it will make sure we fulfill the necessary tasks to obtain it, whether food or water. And this is the same process that occurs in our brains when addicted to drugs. Limbic system controls these basic needs as eating, drinking, mating, protecting our children and our family. It's the center of our emotions, and it helps us ensure our survival. And in the face of danger or perceived threat, activation of the brain's stress system within the extended amygdala drives this fight or flight response, which is critical for survival. But it also plays a critical role in the stressful feelings like anxiety, irritability, unease, which characterize drug withdrawal or alcohol withdrawal after the drug high fades, and thus motivates the person to seek the drug again, to seek relief. This circuit becomes increasingly sensitive with increased drug use, and over time, a person with substance use disorder uses drugs to get temporary relief from the discomfort rather than to get high. The extended amygdala drives the negative emotional state of withdrawal, which it interprets as danger or a threat to our survival, which causes motivation to seek relief, to stay alive in their mind. The binge intoxication stage associated with the basal ganglia, it uses using in excess and the effects or the high, which is caused by a greater than normal increases in release of dopamine. At the receptor level, these increases elicit a reward signal that triggers associative learning and conditioning. In this way, environmental stimuli that are repeatedly paired with the drug use, including the environment, the situation, the people you're using with, and the emotional state of the person's the emotional state of the user may all come to elicit a conditioned fast surges of dopamine that motivate drug seeking behavior and lead to the heavy use or even the binge use of the drug. These conditioned and learned responses become deeply ingrained and can trigger strong cravings for the drug long after use is stopped and even in the face of sanctions or even despite negative consequences. In this stage, the binge intoxication stage, it's where addictive substances hijack the brain reward system. You may have heard that term. Drugs such as opioids specifically hack into this system by binding directly to the receptors that cause the release of dopamine. And dopamine is the messenger or signal that our limbic system uses in order to understand which activities in life are salient or most important. It does this by generating a rewarding, pleasurable reaction. This is how we prioritize which drives are most essential to life. Our brain is not designed, unfortunately, to just create happiness. It evolved to promote survival. It saves all the happy chemicals like dopamine and serotonin for opportunities to meet a survival need. And it is designed to only release in short spurts. Drug hijack this system, and we know this. Our brains are wired again to ensure that we will repeat life sustaining activities by associating them with reward or pleasure. Um, Natural rewards stimulate dopamine release. When you sense something pleasurable, the feeling of pleasure is how a healthy brain identifies and reinforces beneficial behaviors such as eating, socializing, and even sex. The brain takes a pleasurable activity like a special song, the touch of a loved one, the smell of a newborn baby, your favorite food, like over Thanksgiving, eating a slice of grandma's apple pie, and adds to it all the love for grandma and the memories of the shared experiences. The brain releases dopamine that essentially trains the body to remember, hey, I like that. Let's do it again and don't ever forget it. And also, when you eat a great meal or during sex, the reward or sense of pleasure motivates us to continue to engage in these activities, thereby ensuring survival of the species. Just as drugs produce intense euphoria, they also produce a much larger surges of dopamine than those little bursts that they're intended to, powerfully reinforcing the connection between consumption of the drug and resulting pleasure. And all the external cues linked to the experience. Large surges of dopamine teach the brain to seek drugs at the expense of other healthier goals and activities. All addictive drugs, examples here, cocaine, you can see on the chart, prescription opioids, heroin, and meth cause an artificially high level of dopamine, hijacking it by triggering a large surge, not the typical short spurt of dopamine, but larger than nature ever could and larger than nature ever intended, causing the limbic system to sense that the drug is more important than the other drivers of survival. To the person with addiction, the drug or alcohol at this stage is life itself. And the defect? Well, the defect is the stress-induced dysregulation or dysfunction of this brain reward pathway, or hijacking, as Dr. Vokal calls it, that leads to a disruptive neural circuitry and a change in structure and function. And it uses dopamine and other messengers to signal the frontal cortex that the drug is now the most important thing in their life. Basically, at this stage of severe substance use disorder or addiction, um, the drug is survival. There's a new number one in the survival hierarchy of needs. And once the brain has been dysregulated or hijacked, it will force the individual to search for drugs with the same strength as if it were food or even greater. And the rational brain is unable to stop it. Remember, our rational brain does not have the wiring in place to stop those limbic system survival drives. And in severe opiate use disorder, when stressed or in withdrawal or craving, it can cause one to pursue the reward at the cost of everything in their life, even possibly to the point of death. The brain will always remember the one thing that it thinks will save its life when it's threatened by pain or withdrawal or stress or craving, and that's the drug or the drink. And all addictive substances disrupt this signaling and change the brain structure and function. They each work by different mechanisms, but the net result is a release of dopamine from the VTA and an increase of dopamine in the nucleus accumbens. And on the left, you can see where exposure to drugs can change the structure of neurons even in the brain, which strengthens reward pathways and weakens the pathways involved in control. Stimulants like amphetamines can alter the structure of neurons. In this case, the dendrites of dopamine neurons in the nucleus accumbens, more dendritic spines or dendritic arborization or connections are created, creating a much what I would call a super highway in these pathological learning drives.
Hey, Dr. Hunt, this is Marcia. I got a couple requests asking you to slow down just a little bit if possible. Sorry to
Oh,
interrupt
okay.
you, but
Okay. All right. Thank you.
we can tell you're passionate.
Okay. On the right, there are more structural changes evidenced by a decrease in the gray matter, which are the cell bodies of the neurons. This study shows that alcohol, cocaine, and heroin decrease gray matter, which again is the brain tissue composed of neuronal cell bodies. Its density correlates with skills and abilities. The less dense, the more impairment. And as you see in the graph, there is more impairment in the substance exposed brains. This is a time-related decrease in dopamine released in the brain of a person with cocaine use disorder. Drug exposure also changes brain function by decreasing the dopamine receptors, cause dysfunction in the brain's reward system. This reduction stems from repeated overstimulation of the dopamine receptors. This impairment explains why those who develop a substance use disorder do not get the same level of pleasure from the same activities they used to enjoy. Normal things just aren't fun anymore. This general loss of reward sensitivity may contribute to the compulsion and obsession and motivation to use as an attempt to feel good again. And this net loss of dopamine leads to what we refer to as a decreased dopamine tone. And when there's a decreased dopamine tone or less dopamine receptors, less dopamine transporters, you can get anhedonia, which is the inability to experience normal pleasure. They may have a sense of not fitting in or uncomfortable in their own skin, poor attention span, no motivation, apathy, or restless, irritable, and discontent. And these decrease in dopamine receptor activity has also been observed during withdrawal from other substances such as cocaine, methamphetamine, alcohol, and heroin. At the same time, the brain gradually releases less dopamine in response to other things the person once found pleasurable. This impairment explains why those who develop a substance use disorder often do not get the same satisfaction or pleasure from activities they once enjoyed, which accounts for the progression of their disease, as they may attempt to regain the pleasurable feelings the reward system used to provide. The system is now shot. You can think of it as like a rock concert, an overexposure to sound. You can't hear a thing for a while. Well, in addiction, this pleasure deafness, so to speak, may last much, much longer, months to years. And repeated use overloads the circuit in the brain responsible for learning and memory, emotion, judgment, and self-control. Eventually, they seek the drug at all cost, not to get high, but to avoid constantly feeling low and to avoid withdrawal, which brings us to the next stage, which is the withdrawal negative affect stage of addiction, where one experiences a negative emotional state or despair and even pain. An important result of the conditioned physiologic processes involved in addiction is that normal, more healthy rewards are no longer satisfying, and now all the focus is on using drugs to feel normal and avoid emotional, psychological, or even physical discomfort. In this stage of addiction, there is a decrease in the function of the brain reward system, an activation of those stress neurotransmitters such as CRF and dynorphin in the extended amygdala, intensifying the stress and discomfort, which again is motivating to use in order to seek relief. Together, the CRF and the dynorphin provide a powerful neurobiological basis for the horrible negative feelings associated with withdrawal. The withdrawal negative affect stage also sets up future rounds of binge intoxication. During this stage, a person experiences withdrawal symptoms from which include negative emotions and sometimes symptoms of physical illness when they stop taking the substance. Symptoms of withdrawal may occur with all addictive substances, including marijuana, although they vary in intensity and duration depending on both the type of substance and the severity and duration of use. The negative feelings associated with withdrawal are thought to come from the basal ganglia and the activation of the brain stress system in the extended amygdala. As drug use progresses, you engage this stress system, causing dysphoria, anxiety, irritability, malaise, and most common sleep problems, all of which are motivational signs of withdrawal, most of which are pronounced in acute withdrawal, but some remain for long periods of time, pain being one of them. In fact, pain in withdrawal can be worse than the initial pain that one sought out pain medications or opioids for relief. On the right, we talk about positive reinforcement. Um, at first, the drug feels good. It seems like the answer to all your problems. If it didn't, we wouldn't be having this conversation. But over time, they're only using, like I said, to not feel bad, to treat withdrawal, to self medicate, to feel normal, which is negative reinforcement. As humans, we don't like pain, physical or emotional, and we'll do almost anything to not be in pain or to relieve it. We'll do more to stay out of pain than we will do to try to get high. The desire to remove the negative feelings that accompany withdrawal can be a strong motivator for continued substance use. Of course, this process is a vicious cycle. Taking drugs or alcohol to lessen the symptoms of withdrawal that occur during a period of abstinence actually cause those symptoms to be even worse the next time a person stops taking the substance, making it even harder to maintain abstinence. Still a little more on the negative affect withdrawal stage. In the middle, you can see at the top middle that blunting or the burning out or draining of the dopamine system with activation there in the bottom of that stress system. The CRF is increased, which is the brain stress signal. It has a profound role in the behavioral responses to stress and is activated by all addictive substances during withdrawal. On the right, another peptide that drives dysphoric or feelings of illness and anxiety like responses is dynorphin, and intensifying the stress and discomfort, which again is motivating to use and seek relief. This blunted release of dopamine renders the brain's reward system much less sensitive to stimulation by both drug related and non drug related rewards. Interestingly, the main difference in that in addiction, dopamine is released in small amounts when exposed to cues and triggers like people, places, and things, which can come out of nowhere, causing craving and a motivation to use. if we follow the yellow line there in the middle with the blue background, as drug use progresses, you engage this stress system more, causing more dysphoria. You can see the dotted line is the dopamine tone, that sense of normalcy, that sense of well-being. You can see that a person's emotional state is falling well below feeling normal. And the only thing that can do that is repeated use of the drug till eventually um, you can't even get back to normal anymore. Um, in fact, if you check out the star, which I would be consider this as severe addiction, this is literally a living hell, and it's not fun anymore. And opiate withdrawal, they may feel like they're going to die. They're using only to feel normal or to barely function, if only for a minute. Uh, this is not conscience. It's not a lack of willpower or a weakness, and it's definitely not a choice. Under a big enough threat, yeah, a judge, a medical board, maybe even a spouse, they may be able to not choose to use for a little while. But what they can't do is they can't not crave. They can't choose to not crave. That's biologic, and that's in the disease process. The only thing that's going to relieve the stress on the brain, a stress that it perceives as a threat to its own survival, is the drink or the drug. And again, it's important to note that these changes become deeply ingrained and cannot be immediately reversed through the simple termination or stoppage of use. Example is detoxification. We need some level of follow-up to increase the opportunity of being successful. Um, Now we move on to the preoccupation anticipation stage, which is associated with the prefrontal cortex. Um, this is a stage at which one craves and seeks substances over and over after a period of abstinence, even if it's a short period of abstinence. This stage is characterized by disruption of executive function caused by a compromised prefrontal cortex, secondary to the changes in the structure and function. This impaired neural circuitry in the prefrontal cortex weakens the ability to resist strong urges or to follow through on decisions to stop using, even if they want to, therefore increasing the risk of relapse. And once function is decreased or damaged in the prefrontal cortex, in the green there, it is associated with executive function deficits and craving. It causes the loss of a crucial behavioral guidance system. I call it the steering wheel is broke and the brakes don't work. Responses are impulsive and inappropriate, and there's deficits of self-regulation. It also can lead to premature, risky, poorly conceived actions or sensation pleasure seeking. It could be an emotional crisis, and emotions are inappropriate to the situation, either overreacting or completely apathetic and underreacting. There's deficits in attention, lack of perseverance, and then an insensitivity to consequences. They just don't care. I've had several people in treatment risk going to prison just to use one more time. Doctors, pharmacists risk losing their license to practice to use again, and mothers and fathers risk losing their children. And you would say, what were they thinking? And I would say, exactly, they really weren't thinking. There's an impairment in this decision making. Again, not an excuse, but an understanding. Again, gray matter volume, we talked about the cell bodies and the gray matter and the deficits and the less dense in chronic substance use disorders or severe substance use disorder. The more deficits, it's predictable to the time of relapse. The more deficits, the quicker they are to relapse. We know the greater the impairment in the prefrontal cortex makes recovery more difficult. And in this study from Yale, the less activity you have in the prefrontal cortex, the more difficult it is to sustain recovery and increases the risk of relapse. And their addiction also disrupts other areas and other functions and other parts of the brain that work in conjunction with the prefrontal cortex. If we take a look at the orbital prefrontal cortex, it's where we give value to people, places, and things. And when this is damaged or disruptive, we have an inability to properly assign values to rewards, such as family, job, versus the drugs. The drug is now the most important. We look at the anterior cingulate cortex. It's where we pick up on social cues and we guide our behavior accordingly. It determines how we see ourselves through the eyes of others. When this is disrupted, we lose the ability to see just how wrong our thinking is and how our behavior is affecting others. The insular cortex, it's where we may have self-awareness or where the conscious may be attached to the body. It's where they And this is impaired. They can't link their behavior to the consequences. They don't recognize that their behavior is causing a lot of their problems. It's not just impaired decision making, it's also an inability to have self-recognition. Lose the ability just to see how wrong their thinking is. Maybe even responsible for denial. Don't even know I am lying. The memory system also plays a very critical role in addiction. There are strong memory and emotional connections between the hippocampus, a key to memory storage and retrieval, and the amygdala, which is part of the limbic system, associated with processing and evoking emotions like anger, fear, and pleasure. These memory attachments can cause craving, especially during stress or other emotional states like withdrawal or depression or anxiety, which may contribute to relapse. Cue-induced craving, the memory of drugs. This slide demonstrates something that's pretty amazing. It's just how the mention of some items associated with drug use may cause the brain to crave or desire drugs. This study brain scans were performed while subjects watched two different videos. Um, the study compared people in recovery who had stopped using cocaine with people who had no history of cocaine use. And you can show in the nature video, the people with substance use disorder or a history of cocaine use showed no euphoric recall, no um, no excitement to the nature video, but when they showed them a spoon or a needle or a line of cocaine, it lit up like a firecracker. That yellow area on the upper part is the amygdala. It's the part of the brain's limbic system, which is crucial for memory and responsible for evoking strong emotions. It's where that euphoric recall comes from, or romanticizing. Um, for somebody with a substance use disorder, when a drug craving occurs, even if it's cued by people, places, and things, the amygdala becomes active and a craving for the drug is triggered. The left image shows the brain responding the same way to alcohol cues. This happens with both taste, smell, or even a picture of alcohol. On the right, it shows something even more remarkable, that unconscious cues can elicit a brain response. In this example on the right, a 33 millisecond flash of cocaine, which is too fast for even conscious recognition, was shown to patients. They don't even know they saw it, but under imaging, the brain saw it and the brain lit up. It noticed it. Pretty remarkable. And all these changes that I've discussed make it very hard to quit, and provides an often overwhelming drive for drug seeking and use that can be unrelenting. The most prominent are the disruptions of the ability to prioritize behaviors that result in long-term benefit over short-term rewards, and the increasing difficulty, almost impossible, in exerting control over these behaviors, even when associated with negative consequences. So all this disruptive or damaged neurocircuitry, the disease process, as we call it, leads to symptoms. Remember, addiction is a disease that hijacks the brain's limbic system, which due to evolution is the most powerful driver of our behavior. The drug, which the brain in severe substance use disorder actually can equate the drug as survival, outweighs the risk of potential consequences, which contributes to the behaviors we see in addiction, which is why symptoms of addiction are primarily behaviors and have been looked at and even stigmatized as badness. Again, not an excuse, but an understanding. And if you see 1 through 11 there, that's the 11 criteria out of the DSM-5 for the symptoms or the diagnosis of a substance use disorder. 2 to 3 of those um, is mild, 4 to 5 is moderate, and 6 or more is severe. I'll run through them real quick. Taking larger amounts for longer periods than you planned, unable to cut down or stop, spending a great deal of time getting, using, or recovering from drugs or alcohol, have strong cravings to use, problems with work, school, or home, recurrent social or interpersonal problems, giving up social activities or recreation or things you used to like to do because of your use, recurrent use that leads to potentially dangerous situations like drinking and driving, uh, a physical or psychological problem that's worse by your drug or alcohol use, tolerance, which is needing more to achieve the desired effect, and withdrawal symptoms or taking drugs to prevent withdrawal. Six or more of those is considered severe substance use disorder, and severe substance use disorder is considered addiction. And that's when we see most of the pathology that I've shown you on the brain scans. Again, without treatment or some sort of intervention and abstinence, it's difficult to obtain abstinence. There are treatments that can help stabilize the brain and develop stress and coping mechanisms and strategies. There are many behavioral interventions, psychosocial therapy, CBT, DBT, motivational enhancement therapy, family therapy. Trauma is very important. Trauma work, 12-step programs, mutual aid, contingency management, and monitoring all have benefits. Then there's also medications or pharmacotherapy, um, agonist medications such as methadone and buprenorphine for opiate use disorder can stabilize that craving brain while the planning and reasoning process get back in shape. In severe opiate use disorder, um, without some stabilization, just using behavioral interventions, it's almost like building a house on quicksand. They can work well together. Um, Extended absence is predictive of sustained recovery. The first year of recovery is the hardest. 1/3 of those who make it through the first year will relapse in year 2. The odds of recovery increase if patients have been absent for 1 to 3 years. After 3 years, the odds of stable recovery or full sustained remission is close to 80 to 90%. It takes a long time for the central nervous system to heal or reset and for lifestyles to change. After 4 or 5 years of sobriety, however, most people in recovery are no more likely to have a relapse or return to use than those in the general population, which is about 15%. Therefore, with other chronic diseases, addiction requires an ongoing and active disease management strategy. It takes a long time for the central nervous system to recalibrate and for lifestyles to change. After 4 or 5 years of sobriety, um, relapse is less than 15%. A person may enter treatment secondary to external motivation. We see that typically the hope is to transition to more internal motivation, and one does not quit, or should I say quit because of consequences. For the most part, they quit and enter long-term recovery because their life becomes much better without the drugs or alcohol. Nobody wants to be addicted. And once adequate long-term treatment's available and their brain heals and they realize that nothing in life can be improved with a drink or a drug, they have been given a second chance. And that may sustain them. But it's a chronic condition that needs continued support. And like other chronic diseases, addiction often involves cycles of relapse and remission. And the rates for drug addiction are similar to those of other chronic illnesses like diabetes, hypertension, and asthma. Uh, does relapse to drug use mean treatment has failed? I like to use recurrence of symptoms or return to use instead of relapse, but no, the chronic nature of addiction means that for some people, relapse or return to use after an attempt to stop can be part of the process. But newer treatments are designed to help with relapse prevention. If people stop following their medical or their treatment plan, they are at more risk. This means that patients are told what diet they need to follow, what medications they need to take, and what lifestyle modifications they need to make, but they cannot make all these life adjustments and are not compliant with the recommendations. And they relapse by having another stroke or another heart attack or a bout of asthma or even an episode of diabetic ketoacidosis. And all of these diseases create worry and fear of losing the loved one. And these patients are considered just that, patients and as victims. And we even practice harm reduction. If a diabetic does not want to take insulin, if they need, the doctor will try oral medications. Now, how about addiction? The relapse rate's the same, about 40 to 60%. These patients also have a hard time following recommendations, changing their lifestyle, and taking proper medications. They all have environmental stress and genetic predispositions. And what is different is that trauma and is usually a precursor to addiction. It may not be the sole cause, but if a person is predisposed to addiction, trauma will bring it out, and stress. However, society shames the people with the disease of addiction. This is all because of stigma, and the power of stigma prevents people from seeking help. Um, Drug addiction is the most stigmatized health condition in the world. It happens in the best of families. Um, Most people know somebody who has been affected by addiction. Um, Stigma erodes confidence that addiction is a valid and treatable disease. It stops people from seeking help. It impacts care. It deters the public from wanting to pay, and it allows insurance companies to restrict or deny coverage. It poses barriers to jobs, housing, and relationships. So, what can we do? Well, don't define people by their illness. View addiction like any other chronic disease and tell stories of success and recovery. Use non stigmatizing language. We've all heard the sticks and stones. However, language does matter. Words matter. Um, they determine how we understand and perceive our world. They carry power for good and for ill. This is not a matter of political correctness. Until people with substance use disorder are seen as people, until they are provided the same respect and dignity as everyone else, they will continue to die. We have to change the cultural perception of those with addiction. And to do that, we have to change the language of addiction. And that's the easiest thing to change. Abuser, abuse, addict, that evokes more of a willful badness or a moral failing. Substance use disorder evokes perceptions the individual has more is more of a patient of a biomedical process or a disease. If you think about it, abuse is not used in any other healthcare condition. It's usually associated with behaviors such as sexual assault, domestic violence, child molestation. When you think about the language with other diseases like cancer, we use words like patient, fighter, survivor, victim, courageous, endures. My mother died of cancer when I was very young. It's one of my motivations for going to medical school. For years, I watched her struggle and fight, and I only remember her as a warrior, the strongest woman I've ever known. But this has not always been the case with cancer. Cancer was once considered a shameful disease. For example, back in the 30s or even the 40s, one would never put cancer in an obituary as a cause of death because it was perceived as an illness a person might have brought upon themselves or herself as a result of weak moral fiber. That seems ludicrous today, even absurd, right? People treated for cancer are considered survivors, and this is no longer the case today. Look how far we've come with cancer. For example, in the case of breast cancer, many women have told their stories, and everyone has joined in on the fight against this disease. But what happened? Well, we had better science, better research, developed better treatments, created support groups. The women got better. They spoke up. They became cancer survivors. And that's really kind of what I want to see, addiction survivors. Opioid crisis survivors, because it takes courage to seek help, to work on yourself, regardless of the circumstances. Treatment is hard work, but it's worth it. Um, Studies actually compared using derogatory terms like addict or abuser versus using opiate use disorder. And when they were compared, looked at PhD and master's levels therapists, the participants, when they read the scenario where the person was described as an abuser, the thoughts were that they were less likely to benefit from treatment, more likely to benefit from punishment, more likely to be socially threatening, more likely to be blamed for their problems and their difficulties, less likely that a medical disorder played a part. Um, and they should have been more able to control their substance use without help. Just knock it off and pull yourself up by your bootstraps, or just say no, as we know doesn't work. The same study was repeated in the general population, and the biases were even stronger. Because when you're addicted, you already beat yourself up every day. We certainly don't need to be reminded by people that choose a sacred profession and took an oath to help people that they aren't worth it. The power of stigma does prevent people from seeking treatment. Um, and sometimes the media is just plain wrong. Medically incorrect terminology appears all over the media today. In this one, we talk about addicted babies. Babies can't be addicted. The term I like best is opiate exposed. Babies can be in withdrawal, but I described addiction as a disease, and babies can't be born addicted. They can be born exposed. And when we call babies addicted, we shame the mothers, we stigmatize the children, uh, impact the family, and there are public health implications too. The vast majority of pregnant women are motivated to maximize their own health and the health of their baby to be. And women who can't cut back or quit most likely have a substance use disorder. Continued use in pregnancy is pathognomonic for disease. Unfortunately, only 1 in 10 people with a substance use disorder receive treatment. When treatment is provided, it often comes too late at the most acute stages of the disease, when effective treatment is far more challenging and costly than the early stages. It's like diagnosing cancer at stage 4 every time. Treatment would not be as successful. That's what happens with addiction, because substance use disorders have historically gone unidentified for far too long, and timely access to treatment has been far too difficult to come by, and a person's expected to hit rock bottom before seeking help for their substance use disorder. It makes it very difficult to treat at this stage, and by then the patient has lost most, if not all, of their support and their resources, and they may have been stigmatized by society and probably the criminal justice system as well. And yes, patients addicted to alcohol and drugs can be hard to treat. They most often have histories of physical and emotional trauma. They are almost always craving. They are often withdrawing. Patients who are craving, withdrawing, and traumatized can be angry and even hard to handle. But these patients are impossible to treat if the doctor, nurse, therapist, insurance company, or medical facility does not believe they're worth the effort. Again, the problem is lack of adequate long-term treatment, and this is a public health issue. Um, but healing does happen. This is a slide to show that the brain does recover. Keep calm and carry Narcan. This has been a great advancement in helping keep people alive so they can actually enter treatment. And while science has taught us that addiction is a hijacking of the brain, recovery must involve healing of heart and soul. That's a quote from my medical director, Dr. Scott Teitelbaum. Treat addiction, it does save lives. Stigma isn't a thing. It is not something unwanted that attaches to a person and travels with them wherever they go. Rather, stigma is relational, a process by which the reaction of others spoils normal identity. It thrives or dies in the way people treat one another, which means we can kill stigma if we choose to. The stigma around addiction will die if we acknowledge the friends, the neighbors, and family members who struggle with this condition, if we acknowledge our own secrets and our own struggles, if we ask people with substance use disorders about their lives and hopes and hobbies, if we know about their addiction and love them, and we already love so many of them anyway, don't we? And I love that quote from Irving Goffman. And when discrimination ends, and that's when the healing begins. No science, no stigma. Thank you guys for tuning in. I think I ran 2 minutes over. I apologize. And I'll turn it back over to you.
All right, thank you. That was a great presentation. I appreciate all the knowledge and information that we got there. Learned a lot of good things there. So we've had several questions that have come in. I'm going to go ahead and get right to them. One of the first questions is, do you think benzodiazepine addiction will one day have as much concern as the opioid epidemic has reached?
It's already getting a lot of concern, and there's definitely need to be a concern. Almost half of all the opioid overdoses, for the most part, could be in conjunction with benzodiazepines. The lethality of the fentanyl and the carfentanil is what's really driving the opioid epidemic at this point versus even the prescription opioids. But there's definitely a large concern for benzodiazepine use and yeah. We don't really have an opioid crisis. We have an addiction crisis in this country, benzos, alcohol, you name it. So I don't know if it'll reach the proportions because of the lethality of the new synthetic opioids, but it definitely needs to be addressed, and it's definitely becoming a much greater problem.
Okay, thank you. I'm going to ask you to turn off your screen sharing, by the way.
Oh, that's right.
Also, for someone who says they're an atheist, what are some of the better types of treatment or recovery programs that don't require belief in a higher power?
Well, a higher power doesn't have to be God. So, I mean, all mutual aid or AA meetings, NA meetings are different, and some are more geared Granted, some have more of a spiritual tone than others. There are some meetings that like free thinkers meetings. There's actually a free thinkers meeting in Gainesville, but they're still in the right group with the right people. An agnostic or an atheist should be able to fit in fine once they can get past kind of the judgment of the group if that they perceive as judgment. Most of the time they're very, very welcoming to that. And a lot of people in AA or NA are agnostic without a doubt, and that they choose a higher power and the source of nature, energy, love, kindness. There's a lot of ways you can go around the higher power thing without having to get in the religious sense. And the meetings are not intended to be religious anyway. Granted, some meetings have more tone than that than others, so you need to just search out more meetings. But with the tools of online and with Zoom and the internet these days, and with COVID, there's probably a lot of meetings that you can probably search and find options for all over the country and even all over the world, and then and go from there.
Okay, thank you. So one of the questions is, so if the addict is losing their, or has lost their rational thought, how can they remain in treatment? How does that change still allow them to make
Well,
progress in treatment?
what's pretty amazing is you can see some changes pretty quick. 24. I mean, you don't see complete recovery till months to years, but somebody in acute withdrawal, I mean, and most of the time we don't see them. They're wanting to leave. A lot of times when they get to treatment, they've kind of gone through that either through family support or in detox, or unfortunately even criminally or medical issue. Um, but the, early on, right after their last use, they're very irrational. We have a lot of people try to leave treatment early, but what's amazing is with just a little bit of motivation and other people around them, especially the people in the treatment community, they really can bond to them, and they really are our biggest asset in helping somebody stay in treatment, even more than the physicians and the therapist a lot, especially that day 1, 2, and 3. And just after even a few days, they can start to kind of get some of that back. It's just in that active, heavy withdrawal phase that's really a struggle for them. If we can get some time, um, and every little bit of time, that's why AA says one day at a time. Let's just get some time behind us and you can see some success. The brain's an amazing thing. It can heal.
Okay. One of the questions that we got was, so you talked about the brain and the changes in the brain and things like that. Does that apply to cannabis as well?
Yes, we feel cannabis. I showed that one slide with all the drugs interacting with those neurons, and cannabis has probably more receptors than almost anything else. We're still learning a lot about cannabis now that it's become, legalized and in some states recreational. So we're going to continue to have more and more studies. I know it's a controversial topic and not one I really want to address right here, but we're going to learn a lot more about it. But there's no doubt I've seen people with severe cannabis use disorder that would present just like they had any of the others. Not as much as the opiates and the alcohol and the benzos, but with more and more cannabis, we're probably going to see more and more, and we're going to learn a lot more about it.
Okay. So related question to cannabis as well. So if there's someone who says that they're maybe a light marijuana user who doesn't meet 5 of the 12 criteria, what should they do to get support?
Well, it depends on if they're wanting to quit and if they're dependent or addicted, which there is a difference. It's just like there are people that can, drink alcohol normally, and there are people that can probably smoke marijuana normally, and there are people that can take their opioid prescriptions normally, that the brain doesn't increase such a tolerance that it continues to motivate them to get more. So it's really just depending on what kind of consequences is the marijuana having. Now, as we learn more about it, you know, uh, honestly, the studies that show people who smoked the first time when they were older were not as damaged as somebody who started younger. But the key is what kind of consequences is it causing in your life. But they have, marijuana anonymous meetings as well. Any of the mutual aid, AA, NA, work for every substance. Just cross out alcohol and put marijuana. Just cross, NA the same way. You really don't have to go there, and you can mention cannabis, of course, but any of those, the 12-step work, all that will work for cannabis if it's becoming a problem in your life, without a doubt. There's a lot of support.
Thank you. How do you approach someone who has an addiction to alcohol? How would we get them help if they don't think they have an issue and they don't live with you?
Well, it's tough. So I mean, there's always some sort of, intervention, some sort of, at least bringing it up to them. Forcing treatment's tough, but we do know that involuntary treatment does work. We have the Marchman Act in Florida where a lot of people get brought in by family for an evaluation. They come in kicking and screaming, but uh, before too long, they really recognize there's an issue, and they get better, and they're thanking them. But early on, it's a little rough. Um, the key is just depending on, how, again, it all goes back to use despite negative consequences. What's going on with the person and their drinking or their use? Has it caused multiple hospitalizations? Is it causing anger or disruption in the home? What kind of examples can you really lay out concrete that, look, this is causing you a problem, and show and approach them with love and understanding, and not blaming or accusations, but that you love them and want them to get help is usually the best way.
Okay. Is there a way to increase dopamine after you stop using drugs?
Well, one of the most common ways is eating healthy and exercise. Exercise is a very good thing. We see a lot of people really get involved in exercise early. It will come back on its own in time, but for the short and quick answer, exercise.
Okay. Someone asked another question. Says my 22-year-old son has been on medically assisted treatment with Suboxone for a few months. It's recommended he do this for a few years. It seems to be helping. How would doing this for a few years affect his brain, and can it heal during his treatment?
It can heal, and I don't know if you remember, but think the second slide I showed, which showed Dr. Vokal and her doing the brain study, that was actually what that study was. They were looking at the brains of people on MAT or Suboxone and even methadone, and they've done the studies with methadone, and it's so much longer acting than the illicit opioids or the prescription opioids that it does. In the methadone, it showed that it allows time for that, all those stress hormones to heal and the brain to heal. And we feel the same way. That's what it's going to be with Suboxone as well, because they're longer acting. The bottom line is, does it take a little longer or not? I don't know. That's what we don't know, but we do know that it's not like using heroin or oxycodone or anything like that. It's not replacing one drug for another. And yes, a year is usually kind of recommended initially, and to see, and if somebody's life's improving on that, there's really no reason to take them off. But it's a case by case, and I do have that discussion with every patient I see that's on it. It's not something that I definitely don't force on anybody. It's an open discussion, but the data shows that it does help, especially in early recovery, and it does, in my opinion, also allow the brain to kind of reset.
Okay. I have another good question, and I'm gonna say this word wrong, I know. What about the use of psilocybin therapy as being done at Johns Hopkins?
I'm the jury's still out on all that. I'm interested. There's a lot of, addiction being such a hot topic. There's and especially with the opioid crisis, there's a lot of studies going on. So I'm going to, refrain from comment on that yet until I see more.
Okay. Can you comment on kratom usage, please?
Well, kratom, has been used. It's like anything else. It's a substance, and I've seen a lot of people have a lot of problem with it. People that don't have a problem with it, I don't see them. So as far as the numbers of, it's like any other substance. There's going to be a potential that it's going to become very addicted to them and can cause a lot of problems. The internet and a lot of people talk about it. They've been able to kind of detox themselves off opioids with kratom. I don't see the people that are successful doing that. I see the people that kratom has become a significant problem for,
Mm-hmm.
and it becomes just as much of a problem as any of the others. I'll be honest.
Okay. Is there an outpatient program that could help someone get off buprenorphine?
Buprenorphine?
Yeah, sorry.
Yeah. Oh, yes, for sure. That's something to be done individually. Like I said, case by case with their physician. It's usually done over not a long period of time, but a longer taper, so the brain doesn't really pick up on the changes and they don't go into any withdrawal. The one thing about Suboxone or buprenorphine is, the brain does get dependent on it, but it's not determined as addiction. If you took any of those people that were, they'd gotten their lives back and they're working, and you went through that criteria while they were taking their medication, they wouldn't be answering yes to all those like they did when they were doing heroin or fentanyl. So it's really more of a dependence issue than an addiction. And under the care of their physician, they can easily be, say easily, they can be tapered down and come off. And if a lot of patients do that, but if it's doing well and there's no other issues, sometimes you just need to just have that conversation with the physician.
Okay, thank you. Someone asked a question. Says, I'm in Al-Anon for 25 years now. Is there any other support for families?
Online is probably going to be your best bet for that. Codependent no more, different mutual aid like that. Then there's Al-Anon is probably obviously the most popular and the most well known for the care of somebody, with a loved one that they're dealing with or caring about, a spouse or a family member.
Okay, thank you. Let's see. Are there any issues with brain atrophy and dysfunction correlated with levels and consistency of alcohol use? How much should people who are unaffected worry about their brain well-being over the long term?
Did I lose you?
Nope, I'm still here.
Am I still on?
Yep, you're here.
Okay, I lost the thing. All right. Well, alcohol, like I said with that one slide, the long-term effects of alcohol are probably more damaging than almost any other substance. And they're some of the ones that kind of become irreparable, even though some of the other parts of the brain can take over. But there's a state, where alcoholic dementia can set in, and Wernicke-Korsakoff's, a lot of other conditions that are associated with alcohol, especially long-term. And severe use. Now, even not just the brain damage that goes along with it, but the liver can also, and I've seen people that's just drank for a long time, but they don't give a history of super heavy drinking, that at some point the liver just meets its threshold and kind of goes into liver failure. So the sad thing about alcohol, for the most part, doesn't give you a lot of warning signs. It just, you do okay until you don't, and unless it's binge drinking and there's legal stuff, but yeah, alcohol is one of the ones that can cause long-term atrophy and dementia and brain damage, no doubt about it.
Okay. Got another question that says, how do using antidepressants fit in with the model that you were kind of describing, of how it affects your brain and things like that? Can they help with recovery?
Yes, they can, depending on, which came first, the chicken or the egg. But a lot of times we know that a lot of people do self-medicate their depression and their anxiety, a vast number. And we do also know that about 60% of the people with a substance use disorder will have a comorbid or co-occurring anxiety or depressive disorder. So it's really about talking to the patient individually and seeing how they're doing in early recovery and how their depression is doing, and giving them some time versus just starting medications. And then there's other people that you can really get from the history that they've really had a long-standing depression, and they may benefit from starting an antidepressant earlier on in treatment. So again, it's back on individual basis.
Okay. And then we have a question about, do people need a referral to come to the Florida Recovery Center? And then can you also address insurance or people without insurance?
Well, we do take many kinds of insurances. I'm not privy to all of them, and we do take self-pay. You really don't need a referral. You just have to go to the Shands Psychiatric Hospital, to the kind of the intake office area, and say you'd like to either do intensive outpatient, which is kind of an outpatient 3 days a week, or we have what's called partial hospitalization, Or you could live on campus in one of the apartments, or you can actually live at home and commute, depending on the stability of the patient needing treatment. But really don't have to have a referral. You could call the recovery center, you can call UF Health, or you could just show up at the Shands Psychiatric Hospital, and they'll do an intake evaluation assessment and kind of determine the level of care that you or your loved one would benefit from.
Okay. And is that the psychiatric hospital on 39th Avenue near Spring Hill? By
Correct.
Santa
Yeah,
Fe?
you call it
Okay.
Vista or Shands. Yes,
Yeah.
exactly.
Okay. And can you talk more about an abuse?
And abuse is shown to work if it's observed. So if you have somebody, there's other medications out there that really help with craving. Now, Trexone as an oral medication, or Vivitrol as a injection that lasts a month, has really been shown to reduce alcohol cravings and even decrease alcohol use while they're on it. Camprol is another one, or acamprosate. Antabuse is another one that's been around that has its, that if if you're watching them take it, and it's one that makes somebody pretty sick if they drink on it. But the main thing about antabuse is it's more effective if it's observed.
Okay. And then should a person maybe who's had addiction issues see a neurologist to possibly assess brain damage?
Well, the funny thing about the brain damage depends on the patient. Now, a lot of like I said at the beginning, we do a lot of treatment of healthcare professionals. And so we don't scan them. We do what's called neurocognitive testing, which actually psychological testing or neurocognitive testing is a much better indicator of how well a person's functioning cognitively than even brain imaging. Now, if we think there's something going on medically, the brain imaging can be of benefit, but for the most part, neurocognitive testing with a psychologist, a clinical psychologist, or a neuropsychologist is much more beneficial to actually what kind of damage there is to memory and procedural memory and things like that, if there is any. Because it's interesting, you really can't tell clinically sometimes. Some people, just coming talking to them, uh, you would think this person has no deficits, but then they're tested and there are, and then you see some people that you would say, oh, this person has deficits, and they're tested and they're not. So, but the best way is the cognitive testing.
All right, I'm going to give you our last question here, and it's the tough one. So you might not have a magic answer for it, but give it your best shot. Could you give me one or two specific and concrete steps that you could do to help address or confront someone with an addiction issue?
If you're very close to them, I would just I would talk to them, preferably when they're not in high or and lay out your concerns for them without being judgmental and finger pointing. Just say that you're very, very concerned. You're very worried. You'd like you to see a professional. You don't have to take them to a hospital. You can set them up with an outpatient visit with a doctor, just like going to a family practice doctor. You go to an addiction doctor or to a therapist and say, there's this doctor I'd like you to see. You could even, I've had people come in here, I have no idea they were seeing an addiction doctor, but they went for their loved one to see a doctor. And sometimes we can word that stuff better, and so then they show up at a doctor's office that looks like they're more comfortable, and they feel, okay, I can do this, and they don't, not forced into treatment initially or an ILP. They're just kind of seeing a doctor or a therapist, and you just go from there and see how they do.
All right. Well, I'd like to thank you today, Dr. Hunt, for taking your time and helping remove this stigma surrounding addiction and providing all the knowledge that you gave us today. Thank you so much.
Thank you so much. Bye-bye.
Okay, bye.